Hi everyone, my name is Dunja and I'm also one of the pharmacists working from Health House. We will talk to you a little bit more as well about how medicinal cannabis works, and then also its pharmacokinetic and dynamic properties, as well as how it may cause some of the side effects for patients, some of those interactions to watch out for and the contraindications for patients, and the current evidence behind medicinal cannabis. So let's start off with that. Here is pictured the health effects of cannabis and cannabinoids, which was published in 2017. And what they did was collect randomized control trials. So it's a pretty long document, 130 pages, but they summarized it based on the data being conclusive, substantial, modest, or inconclusive evidence behind the use of it. And what they found was that there was conclusive or substantial evidence with cannabinoids being effective for chronic pain in adults, whether you use it as well for acting as an antiemetic for the treatment of chemotherapy-induced nausea and vomiting, as well as improving the patient-reported outcomes of spasticity, particularly for patients with MS. It can also be used to improve short-term sleep outcomes in individuals with sleep disturbances such as obstructive sleep apnea. That was particularly useful for patients with fibromyalgia, chronic pain, or MS. So there's a wide variety of use already in Australia for these indications. Another one I'll mention was the New England Journal of Medicine, which got neurologists really excited about the use of cannabis for drug-resistant epilepsy or Dravet syndrome. And they compared a group with that condition compared to a placebo over 4 weeks. And what they found was amongst those patients with Dravet syndrome, the CBD greatly reduced the convulsive frequency compared to placebo. So that's another really promising result and currently is being prescribed in Australia for that reason. This is a summary of the total number of SASB approvals that were counted by the end of last year, so 2019. And what you can see is that most commonly the indication that it's currently being prescribed for is chronic pain, and there is some other indications for pain like neuropathic pain, migraine, palliative care or cancer pain, for example, as well as fibromyalgia or MS. You also see it being prescribed for mental health conditions like anxiety, anorexia, PTSD. A lot of different variety of reasons. Sometimes you want to boost the appetite, sometimes you want to help with the sleep. So that's why. And then another common indication is the seizures or epilepsy, particularly for a younger cohort of patients, or that chemotherapy-induced nausea, for example. So I'll talk a little bit about some of the research that is currently happening in Australia, but particularly locally, it's really exciting. One has just finished up at UWA, and it was the Zelira insomnia study, which found really good result for improvement in the insomnia severity index score compared to a placebo group. And then also very little side effects for those group of patients. So they tested it on 23 patients. So that had really great results, which we'll consider also keeping the product soon here at Health House. The second one was a dementia trial that is currently running in the University of Notre Dame, and it will run for 14 months with a collection of patients all above 65 years old. And it's within an aged care facility with the aim to try and boost their appetite, act as an anxiolytic, and have that sedating effect as well to help with sleep. Some of these patients may also experience chronic pain without being able to let their loved ones know or the carers. So that's another bonus with the effect of medicinal cannabis, hopefully to really help with dementia patients. And the third one is a pancreatic study that is currently being conducted in Curtin University with Professor Marco Velasca with with his intention to initially increase the lifespan of pancreatic cancer, because it's a very deadly form of cancer. There's 3% survival within 5 years of diagnosis. So what he's trying to do is look at mice and treat them with a chemotherapy agent, gemcitabine, and he found no change in the lifespan, whereas when he treated it with cannabidiol alone, so CBD alone, he also found no change in the mice lifespan. But he decided to combine the two, so gemcitabine with cannabidiol, and he found that the lifespan increased threefold. So now he's collecting patients from Fiona Stanley Hospital as well to get that into human trials as well. So that's really promising for cannabis acting as an anti-cancer agent. Now let's talk about how it actually works. And that's pretty much the most important thing to know, because with the rest of it, with side effects, interactions, contraindications, you'll understand why those exist. So the first thing to note is that THC, pictured on the right but explained on the left, pretty much is actually a partial CB1 agonist. And what it means, it can influence your memory, the mood, the pain, your cognition, the appetite, and motor functions like spasticity. It is psychoactive, which means that it can cause that euphoria and or sedation for patients. But that drowsiness is actually dose dependent, and that's really important to remember when you look at formulations. And it can be useful for cases where patients are getting, say, pain, as well as difficulty with sleep, so insomnia. CBD, on the other hand, that molecule is pictured bottom right. That is not psychoactive. It can help reduce anxiety for patients. It can act as an antispasmodic, and it may also have these mild anti-inflammatory properties. I forgot to say it also acts as that anticonvulsant effect. So the important thing is when you add CBD into THC, it actually acts like a modulator for THC's effects. That's why a lot of formulations are both molecules. And that means that it can have almost a better clinical effect for, say, anti-inflammatory pain or chronic pain, for example. When we look at the side effects, then they pretty much explain themselves in terms of how it worked. I mentioned THC being psychoactive and CBD not. You also need a really high dose of medicinal cannabis to experience those psychological effects, which I'll talk about in a sec. And then most of these side effects do occur early in treatment that are listed, and they are very dose related. So if you start low with a dose for patients and you slowly increase it, you're pretty much going to avoid most of the nasty side effects. The change in dosing is also an option clinically for doctors, because it can produce opposite or paradoxical effects. So for example, if you prescribe a low dose THC, it can act as an anxiolytic, whereas a high dose is going to exacerbate anxiety. And in contrast, CBD, a low dose would make you alert, whereas a high dose causes drowsiness. So I'll just summarize basically when you do tend to see patients for the first time. Most commonly they'll complain about dry mouth, drowsiness, particularly at the beginning, and dizziness. But as we mentioned, if you do a start low, go slow approach, you can minimize that effect. So the psychotropic effect is one a lot of patients get worried about even before starting medicinal cannabis. And that can be minimized by starting the patient on that low dose of THC particularly. So we're talking about 2.5 to 5 milligram per day and slowly increasing that over 2 weeks. Some references say maximum of 30 milligram per day. Some go up to even 40 to 50 milligram per day. So it depends what type of clinician, how experienced they are in terms of how high they will go with patients. When you are administering medicinal cannabis as an oral formulation, it's actually much better clinically, as well as avoiding this psychotropic effect compared to a patient inhaling or smoking cannabis. And that's also going to avoid that high peak THC concentration in the blood. If you include it with CBD, so we're talking about including THC in a formulation with CBD, it's going to negate the psychotropic effect. And that was, if you remember how it works, acting as that modulator. And then if you give patients the medicinal cannabis at night, particularly when they first start on the drugs, it's going to minimize the experience of those side effects. But in general, with us, when patients do call us up or doctors get worried about some of these side effects before prescribing, the intention is to try and help the patients with a condition that you've already attempted a lot of different clinical methods to treat that patient, and the intention is not to get the patients high, it's to help them. So some of the interactions I'll mention here are actually collected from animal studies and not a big sample size. So a lot of this is still not definite in terms of which medications will interact with medicinal cannabis. But we know that the two molecules, THC and CBD, are both lipophilic, which means they're going to accumulate in the liver and increase the risk of the CYP enzyme drug interactions. So these include some of these listed in the green box. So the blood thinners and warfarin, for example. Warfarin, with that you can monitor the INR, but it can increase or reduce the INR, particularly at the beginning. And clopidogrel, it can, normally it increases its concentration with clopidogrel, so that's to watch out for as well. Anticonvulsants are commonly co-prescribed with medicinal cannabis if you're looking at a patient with drug-resistant epilepsy, for example. And that's where you need to consider some of these medications like clobazam, phenytoin, carbamazepine, and topiramate, because a lot of the concentration of those can increase. So particularly clobazam is one to watch out for. So either you can reduce the dose of clobazam potentially, or the medicinal cannabis, and see which way it works. The third one is the opioids, benzodiazepines, and alcohol. The concentration of these can increase, and that means that more likely the patient will experience CNS depression. In contrast, a lot of the doctors currently are prescribing it with the intention to act as an opioid sparing effect. So what that means is, whilst patients are on opioids, for example, when you introduce medicinal cannabis, you remain don't remove opioids or benzos from their regime straight away. So you end up slowly over time reducing the dose potentially because of this interaction. And the last one is the blood pressure medication. Some classes can lower the, well, THC in particularly can lower the blood pressure, particularly initially. So some of these other classes of blood pressure medications can interact per se. So you have to monitor blood pressure, particularly in the first 2 weeks, and then adjust the doses if necessary. When we're looking at some of the potential contraindications, I should say, it varies between state from what I've had a look at and tried to summarize in this slide, but it also varies, I should say, in a lot of the literature. With the patient, the biggest thing to consider is the age. So a patient under 18 years old is more risk of THC affecting the developing part of the brain. So that's one consideration. The second one would be if a patient was pregnant or breastfeeding. Pregnancy definitely is a risk of preterm labor and low birth weight. And because the molecules are lipophilic, as I mentioned before, they're going to enter breast milk. And the literature states that it can remain in the milk between 6 days to 6 weeks. So it's another one to avoid. The last thing to consider is the medical history of the patient. So we're looking at conditions like cannabis use disorder or any unstable mood disorders, anxiety, or a history of psychosis. So a lot of that, if it's not stable or that patient is up and down with that management, then it's better to avoid medicinal cannabis. The other thing is any unstable cardiopulmonary disease, particularly arrhythmias, angina, or peripheral vascular disease. And if patients have liver or kidney dysfunction. Not necessarily that it's a definite no for those patients. It might be a titration of dose that is required because of the way medicinal cannabis is excreted. So when we look at medicinal cannabis itself, we also have to consider what type of administration for that patient and what's going to work best for them. There are a few different types currently in Australia. The ones at Health House that we do have is oil form as the predominant form. There is capsules. We now have wafers as well, sprays, and solutions. And that's it from where I can think of. Basically, all of those tend to kick in about half an hour and last for about half a day. So most of the dosing will end up being twice a day for patients, with the bioavailability going up to about 30%. Some of the newer types of formulations we might see coming up in the Australian market is to use a vaporizer or inhale medicinal cannabis. A lot of that is with the intention to make it act very quickly, so for breakthrough pain, for example, but it may not last as long for patients. But it clinically can be very useful for a lot of patients out there that require that quick effect. So not only for pain, I'm thinking even epilepsy, for example. The other form on there is topical or transdermal. A lot of it is currently being designed as an ointment, cream, or patches. The tricky part is how to get the onset and the duration to be stable and the same every time when you do administer a dose. So a lot of the onset and duration at the moment with the trials and the data is variable. And the last one is smoking, which again has that quick acting effect, but it doesn't last as long. The other thing is when we look at a patient smoking medicinal cannabis compared to a patient administering it as an oral dose, you can see that the plasma THC concentration jumps up almost to 100 nanogram per mil. And that is compared to a patient administering oral formulation where they're doing a few doses over the day. It means that the THC absorption doesn't jump up as much and then also lasts a lot longer. So clinically, that's way better than smoking administration. I'll just quickly go back to the metabolism and elimination. A lot of the cannabinoids are going to be metabolized in the liver, particularly for THC, and then when that is excreted, it enters urine and feces in about 5 days, almost completely eliminated, so 80 to 90%. When we look at prescribing as a guide for medicinal cannabis, this is a nice summary. Basically because the types of formulations that you can get in Australia currently dictate what condition you tend to be prescribing for. So for example, if a doctor decides on prescribing a CBD dominant formula, because of thinking about the way it works, it tends to be very useful for patients with epilepsy, also anxiety and pain because of those anti-inflammatory properties. When you want to prescribe a balanced formula, so an equal component of THC to CBD, that is very useful for mental health conditions like PTSD. If you want to use it for chronic pain or spasticity in MS, it also works. And then when you look at cancer pain or palliative care, it really helps as well. THC dominant formulations are probably what I see as least prescribed, and the reason is because of the cohort of prescriptions. So we tend to see it useful for boosting the appetite or acting as an antiemetic, so particularly for cancer type of patients. So this is a nice summary about the conditions I have already mentioned, and you can see most commonly the balance formula. So a combination of THC and CBD is the products that are designed and available to access for patients here in Australia. And a lot of these are dominated because of chronic conditions, so it makes sense that the majority of these available for prescribing are that combination. You then see second most common is CBD only products. A lot of it is because of the driving aspect, which I'll talk about in a sec. And then THC is the third most common. THC dominant, I should say. All right, so when you look at how to start dosing, it really depends on the brand that you have prescribed. But I'll do a quick general summary for an oil that's pictured here. So most of the manufacturers, I should say, recommend a 0.25 ml dose at night time, and usually for the first few nights. So it's, in this case, first 3 nights. And then you also increase to twice a day dosing after day 3 to 4. So you might do 0.25 BD for another few days, and then it goes up in the volume. So 0.5 BD, which eventually reaches at week 2, end of week 2, to a dose of about 1.5 ml to 3 ml. And that's all based on that THC component, slowly increasing the dose over 2 weeks to avoid the side effects, to avoid the psychotropic effect particularly, and having the best clinical effect for that patient. The other way to best absorb the medication is either dosing under the tongue. So with the oil, you can use the syringe to dose under the tongue so that it absorbs through the mucosa. Otherwise, if patients complain about the taste, they are able to swallow it, but the trick is to have a meal that's a little bit fatty, because they're lipophilic molecules and they're going to absorb much better that way. The application process, a lot of the doctors still get very scared about or skeptical, or think that it's going to take ages, but it's actually so streamlined at the moment with having it being available online. So if you go on to sas.tga.gov.au, it pretty much streamlines you to apply for an approval for unapproved therapeutic good, which is the case for all medicinal cannabis products except for one, Sativex, in Australia. And usually you are applying for the Category B pathway, which basically is for patients that are not terminally ill, so they're not expected to pass away within months, for example. The other pathway doctors might choose is the authorized prescriber pathway, which is prescribing an unapproved therapeutic good, so whatever brand they decide upon for a particular condition of a class of patients in immediate care. And then they have to just provide 6 monthly reports back to the TGA of who they've prescribed for that specific product and the specific indication, I should say. So that's pretty much step 1. Step 2 is, why are you prescribing this medicinal cannabis product for your patient? So that patient has to have already tried therapies with greater evidence for use or safety, and either it didn't work, or it was contraindicated, or the patient experienced severe side effects. And that's why they're now onto the stage of considering medicinal cannabis. The third step is to provide sufficient current clinical evidence. A lot of it is already provided to the TGA, particularly say if you wanted to prescribe for chronic pain. So you may or may not require this step to be finalized from the TGA's perspective. Usually you would require providing literature and the evidence behind the use of medicinal cannabis compared to the potential risks for that patient. If you're intending to prescribe for less common indications like, for example, Tourette's syndrome. Afterwards, the last step, number 4, is to provide care for the patient. So in order to do that, we need a regular review with that patient, usually within the first 4 to 6 weeks. You want to check up on them to see if it's working and either titrate the dose, or if they're receiving and getting side effects, I should say, then also titrate the dose according to response. So I'll just mention as well how much does medicinal cannabis cost, and it's not a one number answer, unfortunately. It will always depend on product availability and how much it costs to import, for example. But since Feb 2017, there has been way more relaxed regulations and in terms of how to import, and that means that product availability has increased threefold almost, which also means that the price on the products has reduced. So for a patient back in 2017, they were paying about $350 per month, and now they're able to drop that down between $200 to $250 a month. So it's about $5 to $10 a day for a patient. The cost will always depend on the indication as well, because some of those conditions I've mentioned require a very high dose, which means you run through the oil or the capsules, for example, much quicker than a patient that's prescribed an indication with a lower dose. And importantly, a lot of private health cover, as well as motor vehicle insurance, is increasing in the cover to cover the patient's cost. And that's mainly to do with the evidence of efficacy slowly increasing, which will always increase with further research as well. DVA patients as well are able to get cover by GPs or specialists, but the GPs or specialists require approval, and they usually have to try and apply about a month before initiating the treatment for that patient. A lot of the cost is saved as well for patients, for example, where they're prescribed medicinal cannabis and preventing hospitalisation. So a lot of the children in Perth Children's Hospital are accessing cover for medicinal cannabis, particularly based on their condition and the cost involved to admit them to hospital and then discharge. So up to $2,000 per stay. So in a way, you're saving money for a patient as well as tax and government. So there's another option to consider as well for prescribers if you don't know about HMRs. HMRs are home medicines reviews conducted by accredited pharmacists, and the intention is because of us understanding the medicines, being experts in the quality use of medicines, we're able to assist patients to use the medicine in the best way possible, but also suggest de-prescribing, I should say, because polypharmacy is still a huge ordeal that we are currently dealing with because a lot of these conditions are chronic. So GPs are able to refer the patients on to an accredited pharmacist that is able to conduct an HMR, and particularly if they feel like there's a risk of medication misadventure, as well as some of those risk factors like comorbidities and age. And you receive an incentive from the government for doing so. So it's a really useful source, particularly with medicinal cannabis now being considered a Schedule 4 medication in the coming months, possibly this year, but more likely next year. With driving, we get asked a lot at Health House whether it's safe or not to drive with medicinal cannabis. And the biggest thing is that medicinal cannabis can cause an impairment from the THC component, but it's unlikely to be a greater impact compared to other sedating medications. So that's one thing to remember. Some patients may already be deemed unfit to drive because of the comorbidities that they have existing. So that's another thing to consider. But in general, across each state, and every state's going to be different, so just check up on that. It is an offence to drive with THC present in your system, so whether that is prescribed or recreational. One thing we know is that CBD-only products, which are not psychoactive and they're Schedule 4 products, patients can lawfully drive as long as the individuals are deemed not impaired by their doctor.